Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast. I am Dan Carter here at Countryside Equine Hospital. I have Dr. Caroline Brown, one of our veterinarians here at Countryside Equine. We're back this morning. We're going to be talking about a little immune-mediated skin disease.
If you don't like dermatology, I'm sorry that there's a lot of episodes that we've been doing, but we love dermatology here.
I think I'm a Georgia grad. You're a Florida grad. We live in Georgia. This is like dermatology central for like horses. If you want to be a dermatologist, I would go to Georgia, Florida, Alabama. Get some skin stuff going down here.
Got all the crazy skin stuff. The stuff you've like never heard of if you live in another state and you're like, oh yeah, we got that here.
Oh yeah, we export this stuff. We got some crazy stuff.
We love it.
I love it.
And I think too, skin is probably one of the most common things that we talk about in appointments. I think no matter what, if you do preventative med or sports med or geriatric horses or young horses or whatever you do, the skin's going to come up at some point.
Absolutely.
And especially today's topic, I think we've said this phrase before, but I think it sees us a lot more than we see it.
I would agree. And to talk about skin, I think you've got to start with it is the largest organ of the body. And I think we often forget it's an organ. It's no different than the liver, the kidney, the spleen, the brain, the heart. Like, it is a functioning, living tissue, and it's the largest one of the body, and it is your first line of defense against everything. And when stuff's wrong with it, it's a bad day. It's real.
And it can act as like a mirror to the rest of the body too, because a lot of things that are going on internally will manifest on the skin. And so sometimes these things that we see on the skin are even more of a kind of sign of something internally going on.
Right.
And with that, the skin itself is very responsive to things going on with the immune system itself. So we're going to talk about what is the immune system. Like, it's a big word that's thrown around all over the place and it means a lot of different things, and it can get really complicated. We're going to try to break it down as simple as we can and then talk about I'd say probably the two big things that we see with the skin.
But I think what you said in the beginning, I think really and truly sums up. We're talking about immune-mediated skin diseases. Most people don't even realize this happens. But one of the things that you said right at the beginning of this podcast is you said, this sees us way more than we see it. Immune-mediated skin disease, I learned, is being incredibly uncommon. But I think it's uncommon because we don't look for it, not uncommon because it isn't there. And when you actually look for it, you find this a lot more than you realize. I'm not saying it's as common as like a pastern dermatitis, like a bacterial dermatophilosis. It's definitely not as common as a rain rot, but it's not as common as those things. It's not like super rare either.
No, it's not.
There. You just got to look for it.
Exactly.
Let's dive into it. Like what's the immunology behind immune-mediated? Because obviously immune-mediated means the body is attacking itself.
Correct. So autoimmune in general refers to the body is attacking itself. And a lot of times it has to do with a specific antigen that has attacked the body. And now the body is, I don't like this thing, let's get rid of it. So when we say antigen, that's something not self. So pollen. Could be a drug. It could be a lot of different things. And so when the body's attacking this thing, we mount this immune response and that helps us respond to it. Autoimmune means that we are now attacking ourselves. And so reasons why this happened is we don't really know. We think that sometimes there is a genetic component to it. We definitely see some sort of heritability with this. We see it in certain breeds seem to present with this more than others. But there's a lot of different flavors of this across all species, across everything. And what we're going to be talking about today is autoimmune within the body that shows up on the skin. And then looking at that too, we're also going to talk about hypersensitivity reactions and how these cells are responding to these antigens that come in.
One of the things I like to think about, because I'm an immunology nerd, but I see things a little different. I like to think about the body everything in the body wears a uniform, right? So all the cells have on a uniform. So when the good guys come in, like, oh, you're all in uniform, y'all are good guys, don't attack you. The problem then becomes the guys like the police that's supposed to be saying, hey, you've all got uniforms on, don't attack you. All of a sudden, these guys go blue on blue and they're like, I'm going to attack my own team. And that's where autoimmune comes from.
Correct.
I'm attacking my own team. And that's the hard part, because now what do you do?
And that's what makes these extremely complicated, and they're not a quick fix.
No.
99% of the time, these are something that is going to require long-term management. There are some things that...
I think that's the key, what you just said. You're not curing this.
No.
You're managing it.
Right. There are a few things that are like, oh, we gave them this drug and the body's going to freak out a little bit. We work it out of their system. We're good. That's probably the one time that might be something that we see with that. But the rest of the time, this is something that is extremely chronic, and we are going to need to manage it. And what's fun about Equine Med 2 is that we are still figuring out a lot of things as we go. And some of the treatments that we have for this are experimental in things. It's exciting for us down the line that we may have some really good options for this. We take a lot of help from human medicine. There's a lot more research in autoimmune diseases in human medicine. They have a lot better ways of diagnosing things and treating things specifically, rather than the way that we have to do it, which is just throw big blanket medications at things. I feel like if there's one sponsor to this episode, it's going to be steroids.
Yes.
Corticosteroids are the main connector in all of these.
I believe that's what holds dermatology together in my mind.
Steroids and antibiotics.
Yeah, if we didn't have steroids, you couldn't be a dermatologist. Like, it's when in doubt, steroid it out.
Steroids, yeah. See if it doesn't respond to antibiotics, see if it responds to steroids.
Trying to arrive at a diagnosis of autoimmune, this is where we typically have to get into biopsies of the skin.
Correct.
I know for me personally, it's when we start looking at skin, and let's say you get there, and usually we get there and they've already slathered every lotion and potion they can come up with, and it's not getting better. And so now they're like, oh, I should call the vet. And so we get out there and we look at it and we're like, because just visual appearance, trying to tell infectious cause, autoimmune cause, in the most of the cases, it can be pretty difficult to...
They can look extremely similar, especially these kind of chronic ones have been going on. And if we've been throwing every magic cream and everything on it, they all kind of start to look the same.
Yep. That's when I start going through the list. Like, I literally get out the paper like, all right, what all have you put on this? What all medications did you have left over from whatever you had that you've been given? And then I'm typically like, all right, we're going to stop everything. We're going to stop any antibiotics. We're going to stop any kind of anti-inflammatories, any steroids, any creams. And that's when I'm going to talk about doing a biopsy.
That's really the only way that you can diagnose some of these.
That's it.
That's really, and we talk about something called a diagnosis of exclusion.
That's like the ruled everything else out.
Correct. A lot of times the way that we do have to get to these diagnoses is we've said, okay, we know that there's not an infectious cause in here. So we know there's no bacteria. We know that there's no parasites. We know that we've ruled out all the other big crazy things. Now we're like, all right, let's dive into the immune system.
And that's getting the biopsy. I was lucky. I had Dr. White when I was in vet school, and I used to actually work on her farm. Dr. White, if you're out there listening, thank you again. But she's a dermatologist. And so she taught me a lot about derm. And one of the things she taught me was how to get a good sample. And I do think it's important. A lot of times I'll have people like, I need you off everything. Give me 48 to 72 hours off everything. And then I'm going to come back and get a biopsy. And as we've learned, there's a right and a wrong way to biopsy.
Correct.
You can't take like this teeny little cute 2 millimeter punch. Like, it's 10 millimeter bigger. And sometimes we have to actually do a wedge resection. And then where we get it's important. So it's not getting a biopsy it's not difficult, but you have to do things right.
There's an art to it.
And so when we tell you, like, I need this thing completely untreated for 72 hours, and you're over there going, it's just going to get worse. I'm like, that's the point.
Actually, it's better if it is worse and we're actually going to see things, because that's the problem you run into with a lot of these is it's slathered with crap on there that by the time you actually get down to the tissue, that tissue's just so pissed off from everything that you've put on it.
Yeah.
Or it's all bombarded down by everything that's been thrown at it that you can't get a good reading on it.
We need something that's active because we got to go right on that margin of good tissue and bad tissue. But we need to be active, like preferably not a healing wound.
No.
We need it to be active and getting worse. And don't worry, once we get the biopsy, we'll start treating again.
Oh, yeah.
But in the grand scheme of things, a few days is not going to be the end of the world.
Correct.
But we need to be set up for success. And I know we've even told them on the phone, like when you hear, hey, I've been smearing Eye of Newt and every lotion and potion under the sun on this, and I've got some magic medicine I got from the feed store and got this supplement. I'm going to be like, hey, why don't we stop everything? I'll be there in 3 days. I don't need everything stopped and come back in 3 days because that's when we need to see it.
Correct.
It's active again. The worst part is sometimes we tell them that and then they call us back in 3 days. It's actually getting a lot better.
Oh.
Maybe it's the lotion and potion. Maybe the kerosine's not the thing to use for this.
The kerosene.
I don't know. I feel like I've seen everything on skin. I'm like, stop.
I had someone recently ask me about the Listerine again, and I'm like, oh, it's still out there. I thought we were done with that, but that is still out there.
If you're listening, Listerine, great for removing plaque, great for killing bacteria in human mouths, not a dermatologist. You know, a great thing I heard, I think it was Jim Orsini said this, if you won't put it in your eye, don't put it on the skin.
Ooh, I like that.
And I think that's probably the best thing I've ever heard. So if you don't want to put it in your eye, don't put it on the skin.
No.
And if you're willing to put Listerine on your eye, you're a tough person.
You're a little crazy.
So yeah,
you're a little freaky.
Getting that biopsy, and then we've got a good pathologist we send these to, and I think that's the other thing is you need a pathologist that likes skin.
Yeah.
And it kind of is up to date on skin and will nerd a little bit.
Dermapathologists are a different breed.
They truly are.
They know what's up.
And it's cool. Pathologists, I always thought, oh, you're a pathologist. And I think we always think, oh, you're a pathologist, therefore you're a pathologist. But they're nerds just like vets. People are like, oh, you're a vet. No, I'm an equine vet. I do lameness and derm, or I'm a vet, but I do internal med. Or like you're like, I'm a vet, but I like repro. Pathologists are the same way.
They have their little area that they like.
Yeah, like I like skin. I like bone. I like the nervous system. So you gotta know.
They have their area that they like, yeah.
Finding a good dermatologist is important. We've got one. They do a great job. I'm picky about where that slide goes. But yeah, and then they call us back and like, oh, you've got pemphigus foliaceus.
We love pemphigus.
So we can jump into our first one today. It's segue.
Pemphigus.
See how I segued that?
Oh, you did segue. That was good. We're learning. We're going to be becoming a professional podcast.
Yes. Yep. So
old pemphigus. So this is an autoimmune disease where you have the body starts producing these antibodies that attack the proteins that are holding the skin together in the epidermis. So if you go back to our first episode in Derm forever ago when we talked about the kind of layout of the skin, the anatomy there, these keratinocytes are the like kind of main skin cells, and they're held together by all these proteins that basically create that skin barrier. And so when you start attacking, that is going to completely disrupt that barrier that we have. And so that's going to cause all these pus little things. There's all this crusting. They'll lose a bunch of hair. It's not typically itchy, but sometimes you can definitely get an itch in there if you start to get some secondary infection in there as well, the more chronic these go. But the problem is that they look like a lot of other things.
Yeah, I like to think about this as if you think about like particle board, you got the wood pieces, right? And then you got the glue that holds all those wood pieces together. The way I describe pemphigus is imagine if you had something made out of particle board and then something started eating all the glue out of that.
And
everything turns to sawdust.
Yes. And that's your skin barrier. When that's gone, then
secondary infection.
Secondary infection, yes. This typically tends to start on their face. Sometimes we'll see it on their legs. I feel like the place I see it is like on the front of the cannon bone.
Front of the cannon bone, pasterns.
Yeah, pasterns,
like
yes.
It likes hair.
It likes white hair for some reason. Yeah, it's usually
coronary bands, pemphigus coronitis.
Coronary band dystrophy.
Yep.
It's a different flavor of this, but yep,
yeah,
same
I forgot
thing.
It used to was pemphigus coronitis.
It was,
and now they changed it to coronary band dystrophy.
That's how I learned it, but I think because we had a case that came through, and
we did.
And you called it one thing, and I was like, "That's dystrophy," and we are like, "Oh, it's the same thing."
Yeah, For whatever reason, they like to change names. I'm like, somebody just pick a name.
And then they don't tell you when they change the name either.
They don't. I feel like this should be a bulletin that goes out. I feel like attention to all veterinarians, we have changed the name.
Well, like navicular, they've changed navicular like 800 times.
I know, podotrochlear syndrome, heel pain.
They never tell us
Yeah,
that they do.
Never get that memo.
No.
So if you're listening to this podcast, you're in charge of renaming. If you can start sending out some memos, that'd be
awesome.
But yeah, pemphigus, that glue's gone. And one of the key histories on this, I think, is because you do have, typically this is accompanied with a secondary infection, is people say, I've been treating it, it gets better, but it just won't go away. And that's usually a big clue that we've got something more going on, because they're treating it and getting rid of the secondary infection, but we're not getting rid of the primary cause.
And that's where that biopsy comes in.
Yes.
Because when we go in there and we take that skin and we see all those changes to those keratinocytes, we're like, ding, ding, there it is.
Boop, there it is. Yeah, and once you've got this, the other thing that goes along with this, I've gotten back on these reports, is they'll tell me we have a secondary solar dermatitis. And I think that's why it hits the white legs, is because the white legs have in the face as well. If you look, it's typically in those white areas. They don't have melanin, so there's no protection from the sun. So they get the solar dermatitis, i.e. a sunburn. And that seems to like trigger or bring this on for whatever reason. Like it tends to make it worse, because the sun definitely is not good for these horses.
And it's part of it too, because again, the body's attacking itself. And so when you get that solar damage, the body's, there's something going on here. But then the immune system just goes out of control. It's attacking it. And then it doesn't know when to stop. Get that too much gene.
Yes. And I think that another hard part about this is the age at which this usually hits. It's usually the later years. And I'll tell you, one of the coolest ones I had had a horse that had Cushing's, actually, had PPID. And as we know with Cushing's, you can have elevated cortisol levels, which actually act a little bit as an immunosuppressant. While these horses get sick easier. And we identified PPID in this horse. We started treating the PPID. And then shortly thereafter, boom, here comes all these skin lesions. And biopsied it had pemphigus.
Oh, no kidding.
And it didn't dawn on me till later, but because a lot of times we don't see a pemphigus. Sometimes we'll see it early on, but most of the time the ones I've seen at least are older. They're in the teen range.
Late teens, yeah, early 20s.
And it comes on, and I got to thinking, I was like, holy crap. I kid you not, I thought the skin was secondary to Cushing's, and I finally was like, this isn't getting better. Let's biopsy it. And I'm willing to bet you that there was enough cortisol to keep that suppressed for that.
Interesting.
That's my redneck logic, I'd say.
That's cool, though. But it makes sense.
I did at the time.
It makes sense.
Somebody smarter than me is probably going to comment like, no, that's not how it worked. But I don't care.
Let me believe what I want to believe.
Yeah. But yeah, and I think that's the hard part, is it hits later in life. So the other thing that can get confusing on this is, and I feel like this is derm all the time. It's like, all right, we got the answer. Good. This is solved. Nope. And then you go look again. And a lot of times I'll see these horses that have PPID, and I'm thinking, oh, we got PPID. The skin won't heal. So we'll get that under control. That's a 6 to 8 week process. Get them regulated. We get them regulated. Life is good. Now we got the secondary infection. We get past the secondary infection, and it's still not getting better. You get the biopsy. Lo and behold, there's pemphigus.
There it is.
So it is. And we're starting to biopsy sooner now. Used to, it would take us a while to get to that biopsy, but we are biopsying a lot sooner now. And I think that's a good thing.
Again, because I think we all learned how to do it in school, and it's something that takes 10 minutes to do. Just go in and you can get stuff back quickly, and then you skip a lot of the guesswork.
Yes. I've gotten now where if I'm looking at a derm case, feeling severity, it's like, I'm going to culture it. I'm going to do an impression smear for cytology. I'm going to grab the biopsy, and we're just going to get it all done. Visit number 1. I'm just like, let's just get this done. So getting the culture in case you got some weird bacteria growing, getting that impression smear lets you look to see if you got ectoparasites, different things like that, and then moving on and getting that biopsy. And next thing, we've decreased the staff. We got about a week dealing with treatment.
Steroids. That's it. That's all we have to say. Steroids.
Basically, immunosuppress them and find the lowest possible dose to keep this under control.
Correct. And again, the theme of this episode is that this isn't going away.
Nope.
That this is something that we're going to be on steroids pretty much permanently. Forever. Until something else comes up.
And some of them we can, and I've seen over the years, I don't warn people, some of them we end up on, we get them immunosuppressed, we get the lesions hit, they're healing, they come down, and then some of them we have to just pulse some steroids to a couple times a year. Others have to live on lowest effective dose, whether that's 200 milligrams every day. Some of them I can get to every other day, every third day. We just have to go through, find out where this horse has to live.
And they can fluctuate too. Like you said, like they can have flare-ups of it, can be under control for a little bit. And like you said, sometimes if they get a lot of irritation from the sun, it can get worse and we need to up them there. It is one of those things that if you're taking this seriously, let's document everything. Let's get some pattern recognition in there, figure out when does it get bad and keep us in the loop with things.
You just try to keep these guys out of the sun, night turnout. If they've got these light colored legs, I keep them wrapped, keep them shaded, and that does tend to help quite a bit. And the thing to remember is with the lesions on the face, people like keep them in the stall during the day, but they got their head stuck out the window. And so you have to think through these things, like how can I keep him during the most intense part of the day? I'm not saying can only go out when it's pitch black dark. Early mornings are good, late evenings are good. Of course, then that's also when our fly bites are the worst. So you can have both. Been there, done that. I've had both. Those intense sun periods, try to keep them out of that. Find out lowest possible dose on steroids, which makes it really difficult because let's say you've got a horse that's going to show. Unfortunately, pred is not on the, is difficult to be used. Now, we can use dexamethasone. Dex worries me a little bit more from a laminitis standpoint. Pred, I don't know that you can find her something on pred. I think if they found her on pred, it's a coincidence. Dex, you absolutely can. And a lot of times that's what we end up having to do is get them regulated, keep them on pred at home, swap them over to Dex if they go to the horse show, and hope we can get them through. So it does become a challenge on some of these horses, like how they can still have a career. And unfortunately, I've had some of these, like with the coronary band dystrophy, I guess 400 milligrams of pred every day to keep this in check.
And unfortunately, topicals just don't really always work on this one either. Not as well as you want them to.
But it makes sense because you're treating it topically, but you're not getting it down to that basement membrane where these where these lymphocytes are really attacking it.
Yep.
Sucks.
Yeah. This is definitely not a super fun one. I think it's a manageable one, but it is something that this is going to be for life. So.
Yep.
Speaking of life,
this kind of leads us into one of my favorite skin conditions. This one is way more rare. We don't see this one quite as often, but MEED.
MEED.
Multisystemic eosinophilic epitheliotropic disease.
This is like one of those bingo card.
Yes.
What is MEED?
I've had a couple of these.
What is MEED?
That's in our, so the multisystemic, it's a type of lymphoma. So the lymphocytes are what tend to be our problem children here. It's autoimmune. The lymphocytes go haywire. And the multisystemic means they're going to attack multiple different areas. So it actually hits the GI tract pretty hard, causes a bad malabsorption. These horses are typically thin. Most of them will have some type of diarrhea. They've got weight loss because the lymphocytes are attacking the GI tract, so they're not absorbing nutrients. Then their skin looks like it is falling off. It is awful.
It's awful.
Sores everywhere. And I've probably diagnosed it as many times on the skin biopsy as I have. Actually, I found it more on skin biopsies than I have because we don't biopsy the GI tract because that's the only way to truly get a diagnosis on that. But we'll biopsy these horses, and it's a poor doer. It's just not gaining weight. They've got horrible skin. People have tried everything. Can't get it to gain weight, and it also has these skin lesions. We do the biopsy, and it comes back MEED, and we kind of all get because we don't cure this.
No.
And like I said, unfortunately, it's multi-systemic, and it's not just skin and not just the GI tract. It's like the whole body's getting targeted.
I've had a few that I've highly suspected of it, and it's one of those that we know the end is coming, and the owners just make a decision. Listen, I don't really want to go through all the money of doing the diagnostics if I know, but I'm like, please let me just know.
And I've had a few over the years. I'll probably find. Back when I was doing more general practice, I was probably finding one every year. I did a lot of derm, but now I find one every few years. I think in the practice, we probably find one every 1 to 2 years. So it's not incredibly common. It just really sucks when you do find it because, again, What do we have for treatment?
Steroids.
Steroids.
And even then, it's a lymphoma.
It's lymphoma. It's cancer.
It's cancer. So there's not really a good prognosis with that.
And it's a lot of steroids.
It is a lot of steroids.
These horses basically live in an immunosuppressed, like we find the lowest possible dose, but most of them live in almost like a constant immunosuppressive type state, which then opens them up to a whole host of other things.
Correct.
Big dose steroids, laminitis is always a risk. Some of them can't even absorb the oral steroids to treat the skin. And so that's why a lot of times we have to start them on a systemic injectable. And so we got them on Dex in order to get the GI tract where it can absorb the steroid, because they've got such bad malabsorption, not even the medication can get into the body. And so you don't want this one. When you get this one on the bingo card, it's not a good day. So we'll do a deeper dive into the whole IBDs, because there's actually about 5 different kinds. This just happens to be one of them, but it's on the list for immune-mediated skin conditions. This one's on the list, and it's not a list you want to be in.
No, we want pemphigus if we're going.
Yes.
If we're going for one, we want pemphigus.
Yes, pemphigus is where I want to be.
Yes.
And there used to be nodular necrobiosis, but I can't remember what they've changed that to. It was some immune-mediated skin condition that came from fly bites, but we won't even get it. They changed the name on. I can't remember what the name is, so we're not going there today, because I really want to get into the next topic on this, and that's when we get into the hypersensitivity reactions, because this one is probably the most common thing that people will see,
especially here, and it's everywhere.
Yes,
it's literally everywhere. So the word of the day is atopy.
Atopy. I love it.
Atopy. I had to look up a couple times how to actually pronounce that, because I've heard it pronounced like several different ways.
What is the correct way?
It's atopy.
Atopy.
Atopy. Not atopy. Atopy.
All right. I've always said atopy, but I'm from Georgia, so we just slur everything together anyway.
The word soup. Yeah. But so atopy is basically just a scientific word for allergies of the skin.
Yes, typically from an inhaled origin.
Usually from something environmental. So going back a little bit and talking about immunology, when we talk about hypersensitivity reactions, this is the body responding to an antigen. And there's 4 different types of things. So and it goes from severity of it and how it responds. So atopy is a combination of kind of type 1 and type 4 reactions. So type 1 is where these antigens, so your pollen, your mold, your insect antibodies, they bind to the IgG immunoglobulins, and that causes mast cells to degranulate. That releases a whole bunch of histamine, and that histamine causes something called urticaria, which is a fun word for hives.
Urticaria.
Urticaria. So that's your initial reaction. And this happens very quickly. This usually happens within a couple minutes of being exposed to this. The problem is that there's also a type 4 reaction that is going on with this. And type 4 is a more delayed response. It involves the T cells. And so that recruitment process takes a little bit more time. And that's where the issue comes in with treating a lot of these things, is that because you have 2 different types of hypersensitivity reactions going on, they're not always going to respond to certain things. Type 1 reactions, they do really well with antihistamines because it is a histamine reaction. But when you have these more chronic things going on, you're not going to hit that type 4 sensitivity. And because of that, we're still going to have all this extra stuff going on, which is where a lot of our treatment for atopy is multifactorial. We need to have a lot of different pieces in here in order to treat it.
Well, and this is why when people say, can I just give Benadryl? And we're like,
oh.
Because, again, you're treating the type 1 with an antihistamine, but you're doing nothing for this type 4. And this is why, unfortunately, we don't get to use Benadryl. Hydrox is limited success. A lot of the antihistamines just don't help horses with urticaria.
Correct.
And one of the things you need to remember is sometimes you'll hear say, oh, it's urticaria progressing to my favorite word, wheals, which is where you have coalescing urticaria.
Urticaria, big wheels.
Yes.
Big hives.
Basically, you have a hive, you have a bunch of hives that get big enough that become one gigantic hive.
One big hive.
I mean, I'm talking about these hives can get so big, look like a dinner plate up there.
Yeah, it's like I've seen some real nasty ones. So
urticaria progressing to
Mhm.
wheals, coalescing wheals.
And they can be itchy. Sometimes they're not. So, whether or not there is a kind of pruritus or an itchiness associated with it, that is going to dictate how we treat it a little bit, because certain things respond better to anti-itch medication.
Pruritus.
Correct.
Pruritus just means itchy.
Yeah, pruritus is itchy. I kind of break it down into, you have your indoor pollutants and your outdoor pollutants.
Yep.
So I noticed when I lived up north, everything really showed up in the winter because all the horses were
Interesting.
inside. Things were more responsive to mold, to dust, to a lot of the like mites and things that live like in the little shadows and things. Versus down here, it's a lot more outdoor pollutants. So it's the pollen, it's the insect bites, it's just all the outdoor crap. That's one of the things that when we talk about managing this, environmental management is probably the biggest thing that we can do. Because it doesn't matter what stuff you throw at them, if you're not looking at when is this happening and what could we possibly be responding to, then we're just going to be fighting an uphill battle with this.
I feel like this is where we sit down and we play 20 questions.
Correct.
One of the last cases I dealt with this was we were having these chronic cases of urticaria. And I finally traced it down. Like, we changed the shaving supplier. That's when this showed up. And it was going away at the shows. The shows, they were using bag shavings. But when the horse came back to the farm, all of a sudden it was showing back up. And I was like, hold up, what's different? We're taking our own hay, we're taking our own feed. It gets better there, come back and we've got it. And I finally found out we changed bulk shavings companies. There was something in those shavings. There was some kind of...
some sort of allergen that was...
Yeah, it was something, like, I almost wondered if they were... Yeah, they should have been pure pine, but was there like some cedar ground into there?
Oh, interesting.
Was there some other kind of weird hardwood that we get? Like, sweet gum trees are everywhere down here, and they're useless for anything but... I don't even know what a sweet gum tree is good for, but it's driving me nuts. I hate a sweet gum. So we never found out what was in there causing this, but we finally traced it back. And this is where you're almost like a detective, right? You're playing 20 questions, trying to find out what has changed.
What changed, yeah.
You find what changed, and then you got to remove that from the equation. So it's like, I hate to do this, but I said, I'm going to need you to bed 40 horses. Like, this, clean this whole barn out, and we're going to need to bed 40 horses on bag shavings and give me a week. And as soon as we did that with no meds on board,
everything was good.
Everything went away. Like,
there in it.
And then I said, okay, now I want you to take and put some of those shavings back in here.
See if it came back.
24 hours later, it's back.
Wow, there you go.
But it took a minute.
Hypothesis. That's science right there.
It took a month or two to finally sort through this.
Yeah.
And because you didn't think, should I check shavings? That wasn't what I thought. Now it's one of the top things on my list because it makes sense. That is pure environment. That's what they're standing in.
Yes. Laying down in, rolling around in.
Breathing in. It's all there. So then you put something interesting like this is, you put on here about cold and heat, thermal urticaria.
Yes. Horses love breaking out in hives. It's like their second favorite thing to do. They get off the trailer and they're just covered in hives.
Yes.
And especially on hot days like we've had recently, it's just they come in and the owners are freaking out. I'm like, give them like 10 minutes.
Yep.
Then they're gone.
Now, thermal urticaria, I've seen this where horses, like the first cold day of the year, like, how does my horse have hives? It's really cold. It's, you got thermal urticaria.
Yeah.
They'll warm up. They'll be fine.
You're good. They're fine. A lot of them, too, you're riding around outside and they're exercising. They come back in, they'll break out in some hives. And those are typically the ones that are not itchy, but they tend to just pop up everywhere. People are like, what is this? Again, sees us a lot more when we see it.
I've seen it too with some of our other medications. I've given dermocidam before and seen these urticaria pop as a sedative, and I've seen it pop up and like, oh yeah, it does that.
Yeah, it does that.
And it's not a true allergic type reaction. It's just for whatever reason.
Again, the skin is a manifestation of a lot of things going on internally.
And trying to get these, like I said, we talked a little bit about this, but when you start trying to get this diagnosed, it's a headache because I've done a lot of IDAT testing, or what we call intradermal allergy testing, and sometimes it's successful, sometimes it's not. And this is where you do a million tiny little skin bleb with suspected allergens to see, okay, does something light up.
Correct.
And I have not, I don't think I've been successful yet.
It's extremely difficult because I went through it on the human side, and you have to be off of everything for at least a week before you go in. You can't have any steroids, any antihistamines. You can't have anything on board, any sort of topicals, because it all interferes with how things respond.
And you also don't need to be in the middle of having a reaction.
Correct.
So if you're currently having these breakouts of urticaria, that's not a great time to test, because at that point they're primed just to react to anything.
Anything, correct.
And so it is.
And it can be seasonal as well. Like if they're really allergic to some sort of pollen that's really prevalent in the springtime and you're testing in the fall and their body's not really geared up to deal with that, it may not respond to that. And the same thing goes with the blood antibody titers as well. If you're just taking blood antibodies, they may not be amounting to that response at this point, so it may not show up.
And this is where, honestly, I think elimination has been my best or most helpful tool on these chronic urticarias. I think this is where I get into history, I get into elimination. And the hard part is sometimes it's not about just eliminating what that horse contacts, but you've got to look at what's surrounding it. So, like, all right, if we're going to change this horse's shavings, we also need to change the shavings around it, because you've got dust, and that dust is still enough to trigger this.
Correct.
And so it's a tough thing, but like I said, you still have to go through that process of that elimination.
Yes. And a lot of times the problem is you can't even avoid some of this. Pollen, if you live down here, good luck.
Yeah. What I've noticed too is, like, we think we have a pollen season down here where the whole world turns green.
Yeah.
The pine trees are dumping this stuff everywhere. That's not what I typically see the cause.
No.
The cause are like right before that, the hardwoods. And those hardwood pollens, I see more with that, and then the grasses. So we have the hardwoods, and then we have the pines, and then we get into grass pollens. The pine, when pollen's blowing everywhere, that ain't the issue. It's the other two.
It's the other guys. That's the ones you don't see.
Yes. And then the fall of the year, everybody forgets we have another whole pollen episode in the fall. Like, we have a whole lot of plants that bloom in the fall down here, shed pollens everywhere. There's your goldenrods. I keep bees, so I'm like a pollen nerd now, because bees like pollen. So that's how I know, oh, there's pollen going on, because I look at my beehives. Treatment, do you want to tell them, or you want me to tell them? You can tell them this time.
Steroids.
And again, it goes back to, this is not just a type 1, but also that type 4.
Correct.
And if you don't treat the type 4, you're not making a score.
And that's where we talk about some things like, if I have a patient we know that this is going to be a problem, because again, this is chronic, it's going to happen all the time. A lot of times it is seasonal. So if we can keep track of when this horse tends to get bad, we say, hey, let's start maybe some antihistamines before things get bad.
Yes.
So we can get a little bit of a baseline in their body. And so that inevitably when that antigen hits them, they're a little more geared up for it. It's not going to 100% prevent it, but sometimes it can at least make it a little bit more tolerable. They're not going to be having as severe of signs. Sometimes it can delay the onset of a lot of these signs, but my kind of top ones are hydroxyzine. I think that is across the board shown that is the best mechanism of action in horses. Cetirizine or Zyrtec sometimes works as well. Again, it's the same with us. If you're dying from your allergies and you pop a Zyrtec, it's not going to do anything.
Right.
But if you already have it on board, it will make life a little bit easier sometimes. But yeah. And these, I always tell people, if you're going to go the cetirizine route, go to Costco, go to Sam's Club, get one of those big old bottles.
Giant bottles.
Yep.
And like I said, it may work, it may not.
Yeah, exactly. If they're deep in one of these type 4 reactions, it's not going to do anything.
Yeah, sometimes we have to get them on a steroid, and then as we start getting under control, then we can start layering in the cetirizines or the hydroxys. That's where weaning off that steroid, it'll maintain them. My new go-to is Apoquil.
Yeah, I know you're really big into it.
I have been amazed at how well it works. And the other thing is, it's legal to show on Apoquil, and that's a lot of my horses have got to show. Hydroxyzine, not legal to show on. So we have to look at the Apoquils. And again, what I've seen with it is, if you're having this full-blown reaction, Apoquil's not going to get it under control. This is actually a dog medication. It's not technically labeled for horses, but I've used it for quite a few years.
I think they're working on the label from what I've heard.
Understand.
Yeah. And the whole idea is that it helps break up this itch cycle.
Yeah, it works as a JAX2 inhibitor. And so it works on these JAK cells to which kind of goes upstream before the mast cell or the T cells really get geared up. JAX is involved in that. It's just another pathway. So it goes north of where the problem really starts. But again, a lot of these, when they're having that full breakout, I've got to do the same thing. I've got to get them on steroids, usually a high dose for a short period of time while I'm putting them on the Apoquil. Unfortunately, a lot of times it's twice a day at first, and I can get them down to once a day, sometimes every other day. But I tell you, we have to get everything under control, and this will help maintain it.
Correct.
Downside, it's not cheap.
It's not cheap.
It's not cheap, but it is highly effective, and it's a lot safer than a steroid.
Yes.
And I think that's when you start looking at it. Yes, Apoquil is expensive, but what's really expensive is laminitis. Laminitis is really expensive.
Yes, it is.
So,
yes, it is.
And plus, we can show on Apoquil. I have a hard time showing
on steroids, or laminitis.
Or laminitis.
And I've used the targeted immunotherapy too. There's some commercial tests where you do take a blood sample and get some antibody titers and then create a specific vaccine for them. They're really easy to use. They're actually extremely affordable. I've had some pretty good success with it. I think it really depends on the case, and it also depends too on how our management works. The best I've seen is where people are doing the immunotherapy with environmental management as well. But I've had some good success with it. I think we've talked in the office and it's kind of 50-50. Some people are like, yeah, it works great. Some people are like, meh, not impressed. But
I hadn't had great success with it. Oh, you have. And I think this goes back, if I had to tell you the theme of this, it is you're fixing to up in a trial and error land.
Yes.
The only thing that works every time is, you can say it, steroids. That's the only thing we got that works every time. But then, like I said, we got to find something else. So I think we end up going like, all right, we'll get them on steroids and then let's try to wean them onto hydroxyzine, cetirizine, Apoquil. I've tried the azathioprine and I've not had good success with it, but I think it has to do with the T cells that it targets. I don't want to over nerd here, but the azathioprine targets a different T cell than what we need from some of these allergens.
Yeah, they work really well in dogs for some reason. Yeah, they use it a lot in dogs, that and cyclosporin. They tend to do that in dogs, but horses they can't respond to anything that works in any other species because horses.
So yeah, there's going to be a lot of trial and error. So I tell you, if you got a derm issue, you're going to need a patient. This is a marathon.
Yes.
It is not a sprint.
It's like a forever marathon.
Yes.
Yes.
And it's really the same in people when you talk to people like you've been through it. It's not you don't go in Monday and you're cured by Wednesday.
No.
This is going October, and we'll hopefully have this knocked out by
next October.
Following October.
Yes.
But yeah, so it's a process. And I know me, when I'm going through looking at these, I got like a whole plan. This is my plan. This is what we're going to do. And I just have to go through and start checking boxes off and, try to hit the right. So yeah, great episode, Dr. Brown.
Cool. Yeah.
Appreciate
this was a fun one.
Yes.
I've been waiting to do this one. I've been like, this is fun to me.
Yes, this is a blast. And derm is really cool. I like derm. And it's cool talking about it.
And if you don't like derm, sorry. But
yeah, sorry.
This is the derm podcast now.
Yeah, but it's our podcast. So we get to do this. It's our podcast. We get to do what we want to do. So yeah, thanks everybody for tuning in. Thanks for keep sending those suggestions. We're working to get to them all. Like I said, we do still have real jobs, so we can't sit here and podcast all day. We do have to actually have to go to work. But thanks everybody for being here. Dr. Brown, thanks as always for being here early in the mornings when we do these. And thank y'all for listening. Keep sending your comments in. Give us a thumbs up, a like, a share, tell your friends about us. We just enjoy this. We want to keep getting good information out there for everybody, telling y'all what we know and best way to hopefully care for your horse. So
yeah,
thanks for tuning in from all of us at Countryside Equine Hospital. Big thank you. Y'all have a great week.
Bye.
Take care. Pin drop.